All right, let's just dive right into this. Welcome to the Explainer. If you're a focused learner looking to completely master the complexities of Listeria syndromes, and specifically their strict treatment protocols, you are in the exact right place. Today, we're running through a rapid-fire clinical refresher, and it's designed specifically for high-yield exam review. We're going to explore exactly how this pathogen operates, who it targets, and honestly, most importantly, how to treat it without falling for those classic diagnostic traps.
So here is our visual syllabus for today to keep us oriented. We'll be hitting gut and blood syndromes, then neurological listeria, followed by fetal and neonatal infections, and we'll wrap it all up with those high-yield exam traps.
Okay, Section 1, Gut and Blood Syndromes. Let's look at the baseline presentations before this thing breaches your deeper defenses.
Starting off with febrile gastroenteritis. Now, in healthy folks, this bug actually needs a pretty massive inoculum to even take hold. And when it does, it's typically a really fast, self-limiting illness. We're talking just 1 to 3 days. Clinically, you're going to see fever, diarrhea, and a headache. But here is what's absolutely crucial to remember for your exams. Routine stool cultures won't even help you diagnose this. Because it clears up so fast in healthy individuals, the treatment protocol is strictly supportive care.
But here's the thing. Listeria doesn't always just stay neatly localized in the gut. No, it can aggressively cross over into the bloodstream of vulnerable patients, causing bacteremia. Now, what's really interesting and dangerous about this is that it's the most common invasive form of Listeria, and it heavily targets the immunocompromised and the elderly. When it hits the blood, the clinical picture suddenly shifts to fever, severe chills, and myalgias. It is urgent.
46%. Let that sink in. That is the staggering 3-month mortality rate for Listeria bacteremia. It's a highly lethal progression for these vulnerable populations. Also, you definitely want to note the classic laboratory association here, which is monocytopenia. To fight this off and actually save the patient, the protocol mandates a full 2 weeks of ampicillin, sometimes combined with gentamicin. The stakes escalate really fast.
All right, moving on to Section 2, neurological Listeria manifestations. We're breaching the blood-brain barrier now.
Okay, so we've left the bloodstream and we're entering highly tested exam territory. Here, we're looking at meningoencephalitis. Again, our target demographic here is immunocompromised and elderly patients. The classic triad you want to watch for? Altered mental status, fever, and focal neurologic deficits. But when you look at the cerebrospinal fluid findings, the CSF, this is exactly where exams will try to trick you. You're going to see a less pronounced pleocytosis, meaning a white blood cell count of less than 1,000 in about 60 to 75% of cases. And glucose? It's low in only 30 to 40% of cases. Oh, and a major trap to look out for, the gram stain is often just entirely misleading. Because of how severe this is, we have to step up our treatment duration to 3 full weeks of ampicillin.
Next up, we have an absolute classic board exam buzzword for you, rhombencephalitis. This is a severe infection specifically localized to the brainstem. But there is a glaring exception you have to note here. This disproportionately affects otherwise healthy older adults. That is incredibly unusual for invasive Listeria, right? Usually it targets the immunocompromised. So that's a major red flag to remember. For this specific syndrome, getting an MRI is absolutely essential for your diagnosis.
And this brilliantly illustrates a highly tested biphasic progression. It's like a 2-part trap. Phase 1 seems entirely routine, just a fever and a headache. But then, days later, phase 2 hits, and it hits hard. We're talking asymmetric cranial nerve palsies, ataxia, tremor, hemiparesis, and really pronounced cerebellar signs. And it actually gets worse. Roughly 50% of these patients end up facing respiratory failure. The real trap for clinicians, the CSF is minimally abnormal during all of this.
Our final neurological issue here is the brain abscess. This is typically seen in immunocompromised patients presenting with positive blood cultures. Now, a normal CSF profile and a brain abscess? Surprisingly, yes. If there's no concurrent meningitis, the CSF can look totally normal. Let that fact sink in because it's a huge clinical differentiator. Clinically, this can easily mimic a malignancy on imaging, which leads to super dangerous diagnostic delays. Eradicating a brain abscess is incredibly tough, so the treatment requires a massive 6 to 8 weeks of continuous ampicillin.
Let's move to Section 3, fetal and neonatal listeriosis. We're looking at vertical transmission now.
Let's take a deep breath here because we're moving into one of the absolute most devastating realities of this pathogen. Granulomatosis infantiptica. It's a severe, systemic in utero infection. It literally causes disseminated microabscesses and granulomas all throughout the developing fetus, specifically targeting the skin, the liver, and the spleen. The outcome here is just heartbreaking. It is overwhelmingly fatal, usually resulting in stillbirths or infants who tragically pass away very shortly after birth.
Now, let's see how this builds for neonates who do survive or who acquire the infection later. It splits into two distinct clinical pictures. Early onset hits premature neonates under 48 hours old, usually presenting with sepsis. This timing basically screams in utero infection. By contrast, late onset affects full-term neonates at around 2 weeks old, presenting with meningitis. That points to perinatal or postnatal acquisition. So remember, early means premature and sepsis, late means full-term and meningitis. It is a vital distinction to lock in.
Which brings us to Section 4, high-yield exam traps. Basically, what not to do. Okay, let's synthesize these treatment timelines so you can map out the escalation. 2 weeks is your baseline for bacteremia and early neonatal sepsis. 3 weeks is required once the infection hits the central nervous system, so that covers meningoencephalitis, rhomboencephalitis, and late neonatal meningitis. Finally, the longest haul. 6 to 8 weeks is strictly reserved for a brain abscess. And notice the constant anchor here. Everything is centered around ampicillin.
But wait, what about empirical treatments before you even know it's Listeria? Well, here's the absolute crucial warning. Cephalosporins do not cover Listeria. If you empirically treat a bacterial meningitis patient with something standard like ceftriaxone, you will completely miss the Listeria infection. You absolutely must add ampicillin to your empirical regimen if the patient is pregnant, elderly, immunocompromised, or a neonate. If you forget this step, the patient is effectively untreated.
Finally, let's frame our clinical decisions around the avoid list. First, avoid dexamethasone in neurolisteriosis. Why? Well, even though it's helpful in some other types of meningitis, with Listeria, it's actually associated with significantly reduced survival. It actively makes things worse. Second, if your patient has a penicillin allergy, TMP-SMX is your standard alternative. However, you absolutely must avoid it in the first trimester because of the risk of neural tube and cardiovascular defects. And you got to avoid it in the perinatal period because of the high risk of kernicterus. Timing is literally everything for pregnant patients when choosing this alternative.
So we've seen the devastating effects, the incredibly strict timelines, and the massive blind spots in standard therapies. I want to leave you with this provocative question to really think about. Since empirical treatments with cephalosporins completely miss Listeria, how many fatal neurological cases do you think are initially misdiagnosed as standard bacterial meningitis before the right antibiotics are finally added? Keep that in the back of your mind next time you're evaluating a vulnerable patient. Clinical vigilance is everything. Thanks for joining me on this explainer. Stay sharp and keep learning.